So, good evening and welcome everybody to this Learnings from ADA session. So, today is day 9 of these sessions, and we've had exceptional reception from everybody for these sessions. So, we have over 8,600 registrations till date. So that shows the success of the program already. It's immense. And the response we have, and we cannot start without thanking our sponsors for these sessions. So the sponsors for today are Mankind and Sinocare. So thank you, sponsors, for these sessions. So, and the first slide that all of you saw was the slide to the February Diabetes India conference. So the registrations are already open for this conference. Kindly go in and register yourselves, be the early birds for registrations. So this again is not going to be possible without some of our key leaders, Dr. Bansi Sabu being one, and then Dr. Amit Gupta and others. So we'll start off today with introducing our moderator. And before we do that, I'd like to encourage all our listeners. First of all, thank you for joining in. Secondly, kindly go in and put any of the questions you may have from experts in the field in the chat box. We'll ensure that they are transferred over and they are kind enough to answer those things during the panel discussion at the end. So while we start this off, our moderator for the day, Dr. Bijay Patni. Dr. Patni, thank you so much for taking time out to be moderating this session. And he's a consultant physician and cardiodiabetologist based out of Canada. He is the head of the department Diabetes Wellness Clinic there, and founder of Diabetes Research and Welfare Association. So thank you, sir, and over to you.
Thank you, Uma. Small correction. I'm based out of Calcutta, not from Canada. And right, so basically we'll start with the two session today. And we have erudite speaker like Dr. Anjali Bhatt will be taking both the sessions. And okay, now can we make these few corrections, Uma? Hello.
Yes, sir, we're putting that up.
Yeah. All right. So these are all learnings from ADA 2024. And today we have Dr. Anjali Bhatt, who will be taking both the talks today. And she is an erudite speaker. She will be speaking firstly on the learnings as far as primary care is concerned, what we learned from ADA 2024. Few specific inputs were given, and this is going to speak on that. She is a founder, director, and chief consultant at Diabetes and Metabolic Center at Pune. She is an adjunct faculty at Symbiosis Medical College for Women, Symbiosis University Hospital Research Center. She is a consultant at MMF, Joshi Hospitals, and Saswat Group of Hospitals, Pune. She is the ex-alumnus of CMC Vellore Residential Fellowship in Diabetes. She is passionate about patient care research, teaching, forming a curriculum for various courses and community-based activities. She's done an MD in medicine from Mahatma Gandhi Institute of Medical Sciences, Wardha, stood second in the university. She's trained in the prestigious Department of Endocrinology at CMC Vellore. She's a former consultant Chilaran Diabetes Institute, Pune. She also have got diploma in endocrinology and MSc in endocrinology by University of South Wales, UK, and has contributed many publication journals as well as books and invited for talks to many conferences. She also passionate, apart from that, lots of hobbies. She has swimming, watercolor painting, writing, reading, traveling, music, and motherhood. Probably all will be reflected in a talk. So thank you, Dr. Anjali Bhatt, for joining today, and it's all yours.
Thank you, sir, for those kind words. Let me share my slides. Just let me know if the slides are visible properly. Is the slide visible properly?
Visible.
Sure. So we have the ADA this time was in Orlando, and we're just back a week before from there, and we are happy to share what we learned from there so that we can use the relevant information in our clinical practice and improve our patient care. So today, the first talk that was allotted to me was primary care council, and what do we learn from the aspects of making the primary care better. Now I understand that the primary care, what they define as in US, is not similar to or relevant to the primary care that happens in India. But I guess the general practice that happens in India quite is similar to the primary care that happens in US, and there are a lot of learnings from the primary care that was discussed there, which can I think be reciprocated to the general practice that happens in India. So we'll just see what primary care initiatives are being taken in US, and we can find them relevant in general practice as such in India, of course, from the government as well as the private sectors. Then, what are the screening opportunities at primary care? What can we do about obesity management in primary care? How can we make better use of continuous glucose monitors in primary care? And how can we make a team building activity or strategies with inclusion of diabetes educator to make diabetes care better at primary level? Now, similar to the data, I guess a lot of our patients are mainly managed at general practitioners and a physician level, and very few would actually go to endocrinologist or tertiary care center just for management of diabetes. Mostly they'll reach there when they develop some complications, so they're not because they're not getting controlled at that level. So most of our patients are actually getting managed at a primary care level, and that is why I think what they are also talking, and I find it relevant to our side also, that the primary care needs to be comprehensive, continuous, proactive, and coordinated. That means that at primary care level, we need to have physicians who are taking the holistic care of the patient rather than just looking at diabetes, because we hardly get patients who come to us only for management of hyperglycemia. It's mostly their multiple other aspects of their life are affected throughout the natural course of their disease. And I think a comprehensive care provided by a physician or a primary care provider is important. It's a continuous care because they are with the patient for a long period of time. Proactive means that rather than trying to wait for complications, preventive aspect of diabetes management needs to be incorporated at the primary care, and then coordination between different team members that can also happen at that level. So, what are the screening opportunities? It may not look like a continuous presentation because I have taken snippets from primary care, multiple talks that happened on primary care, and just took out what all will be useful to our population. So, it's not going to be a continuous storytelling kind of a presentation. I'm just taking small pointers that I found were useful which will be relevant to us. So we know, but still to reiterate that at primary care, we must make sure that we include urinary albumin creatinine ratio, creatinine and EGFR for screening nephropathy, then retinopathy screening. Even though we may not have specialists, ophthalm specialists, then the AI-based retina cameras can be used for screening at the primary level, and annual foot screening, which we all know should be done with monofilament testing. Now, second was, how do we address obesity at the level of primary care? Because it's a chronic condition, I'm sure most of the other branches, including medicine, surgical branches, orthopedicians, gynecologists, all these people are also going to deal with people who come up with obesity. And I think it's important that obesity is identified as well as uh, considered at this level. So at that level, even though in our setting we do not expect discussions regarding surgery and anti-obesity management at primary care level, but what we can definitely do at that level is, one, identify people with obesity, emphasize lifestyle changes, make sure that when we manage diabetes, we're not giving medications that are making the patients gain weight. I think that are the things that we definitely can do at primary level. and then getting known the new drugs that are coming up for anti-obesity management is also important, so that proper referrals of the patient can be done. Then evaluation and management of, or at least screening of, the chronic complications or associated comorbidities. One of them being MASLD, which is again a new terminology that was used, metabolic disorders associated liver disease, and their screening and prevention should be done at the level of primary care. And a very simple scorings like FIB-4 should be incorporated at the primary care level, so that we can identify them, try to see what can be done from the prevention aspect, and if required, referral to a higher center. Now, apart from just screening, the chronic management of liver disease like vaccination, avoiding NSAIDs, avoiding instructions regarding avoiding alcohol, and then managing other aspects of diseases like sleep apnea, hypothyroidism, depression. These needs to be identified and managed at a primary care level. As I said, FIB-4 can be incorporated, very easy to do. Just need to add liver function test and hemogram in the routine investigations that are done at primary care level, and we can get a score. Coming to continuous glucose monitoring in primary care, even though the primary care in US is now heading towards using continuous glucose monitor at a large scale, but I think in India, definitely continuous glucose monitoring can be easily accepted at the physician level. And we need to identify what are the barriers to use, and then overcome them to make sure that continuous glucose monitoring can be incorporated at the physician level. One thing is that we have been thinking that diabetes is a specialty and is treated mainly by super specialists. We know that now that's not the case. With increased awareness, lot of conferences happening, lot of learning to the physicians. Even the difficult to treat diabetes can be managed at the primary level or physician level, and that is why I think continuous glucose monitoring will remove that barrier. So first thing that the physicians think is that only individuals who are treated with insulin will benefit from continuous glucose monitoring, and that is not the case. Many people who are on oral hypoglycemic agent or even non-hypoglycemia potential anti-diabetes medication. Nowadays, even people who are on lifestyle modification would also accept continuous glucose monitoring to monitor to see how the lifestyle changes are affecting the blood glucose levels. So don't think that continuous glucose monitor is only for insulin treated patients. Nowadays, even non-doctors, the fitness enthusiasts are also using continuous glucose monitors. So definitely primary care physicians can accept continuous glucose monitor and include it more and more in the patient care when it comes to managing diabetes. Third barrier is people think that it takes a lot of time to use continuous glucose monitor, interpret the report, and then do the treatment. And that's another barrier. People think I don't have time to use continuous glucose monitor. And I think there is where a diabetes educator or a team of people who may not be doctors but can manage continuous glucose, at least the technical aspects of continuous glucose monitoring, like applying the monitor is very easy, taking out the report is very easy. And once we will get well versed with how to read the report and how to correlate it with the anti-diabetes medications as well as insulin, I think with the help of the front office and back office or a diabetes educator or a nurse, maybe at even an A&M can be very well trained to help us to use the continuous glucose monitors. And if these things can be incorporated in our practice, I think continuous glucose monitor can be very well used at this level. Now, another thing we thought was the continuous glucose monitoring is expensive. Now, expensive and cost effectiveness of a therapy is so subjective that sometimes we might get small expenses used in such a way that the larger expenses like hypoglycemia and hospitalization for hypoglycemia can be avoided. So if we look at it from the cost effective point of view, continuous glucose monitoring now is not as expensive as we thought earlier it would be. Because nowadays, even continuous glucose monitors are available over the counter. I mean, Of course, we know that the Libre by Abbott is available over the counter, not only in US, but also in India. It's available on online platforms like Amazon, and people are using it without even intervention of a doctor. But I think that is causing more harm than good to the patients. And that's why I think it's important that physicians and other specialists make themselves aware about availability of continuous glucose monitors and incorporate in their practice. And that's why I think the education of non doctor people who are diabetes educators, nurses, nutritionists, exercise therapists should be made aware about diabetes care, and who can play a very important role in a team management of diabetes in our OPD. So with that, I thought these were the points from the primary care learnings that might be relevant to our settings and would be useful for us. And I'm open if there are any questions about this.
Thank you, Dr. Anjali. I think you had made few points, particularly what was talked about in the ADA, and definitely we are going to discuss about it a little later after the second talk. But prior to that, I hand it over to Uma for a commercial break. Right, Uma?
Yes, sir. Thank you. So we'll now request the tech team to play the.
At Mankind Pharma, the dream is to provide innovative solutions by delivering innovative and affordable products which improve the quality of living and save lives. Started its journey in 1995 with a vision of becoming the most admired pharma company in India. Mankind currently has 14 state-of-the-art US FDA compliant manufacturing units and a world-class R&D center. As a fully integrated pharmaceutical company, our offerings and our strong portfolio of businesses and products ranging from pharma to popular OTC and FMCG brands provide us the strategic benefits of integration that allow us to perform our best in an increasingly competitive market. Located in Manesar, Delhi, NCR, this 75,000 square feet state-of-the-art research facility has a dedicated team of 200 highly skilled scientists involved in complex and innovative research. Here, we strive to leverage our world-class discovery, development, expertise, and operational excellence. Our QC department has all the latest instruments for analysis of API, finished products, packaging, and related materials used. All our quality control activities and equipment are fully supported by approved WHO and GMP documentation procedures. Our ultimate goal is to help people live healthy lives. The injectable.
Thank you. That is a big thanks to Mankind Pharma, one of our sponsors for today. Thank you, sir. Sir, over to you.
Thank you, Uma, once again. And the next talk again will be taken by Dr. Anjali. This will be a very interesting one because it's more like a debate where probably we are looking into diabetes prevention program versus the GLP-1 receptor agonist. Now we need to understand which tool is better as far as obesity is concerned. So let's hear from Dr. Anjali Bhatt.
Right. So, yeah, I know it's Dr. Nita Deshpande written there because she was supposed to take these slides. But nonetheless, because she couldn't come, I am replacing her to discuss about this very interesting debate which happened in ADA, and there was a lot of noise about half of the audience talking about lifestyle, and the rest half was very excited about GLP-1 receptor agonists. There is in last 10 years, I guess we learned in a very big way that lifestyle modifications can actually reverse the hyperglycemia part of manage diabetes, and the diabetes being reversible was a very big talk of the town for last couple of decades, I would say. And what that has created is that it has made us realize that it's actually management of obesity and not the management of hyperglycemia. What we then started calling it as an upstream approach, because what they say is that there is a common soil of systemic inflammation and certain other aspects which makes the energy homeostasis abnormal, and a person gains weight, and the excess weight then leads to branches to development of metabolic complications like diabetes, and on the other hand the cardiovascular disorders. And rather than treating hyperglycemia, which was considered to be a downstream approach, treat the weight as an upstream approach was at the heart of the debate that happened. So battling the obesity epidemic is the most important state in that battling the diabetes, that was considered as an upstream approach, while lifestyle modification was considered as a more natural way of managing obesity, and that was put up as an important case as to a whole life a person living with diabetes requires a lifestyle modification. So the question here, which was supposed to be the main thing to be answered during debate, was that is lifestyle modification alone enough, and is lifestyle modification sustainable? Is lifestyle modification for everyone? And are we able to do enough justice to the epidemic of obesity and diabetes by just giving lifestyle modification? Is lifestyle modification the intensity of lifestyle modification possible to give to everyone, the kind of intensity that is required to make people lose weight, like repeated consultations with dietitian, repeated consultation with exercise therapist? Are these practically possible to the large amount of people that we are dealing with for diabetes and obesity? So very interesting debate happened between two very good speakers in ADA. And the first slide that was shown was diabetes prevention across lifestyle intervention trials. So you can see multiple trials here, which were shown as a meta-analysis and systematic review of US Preventive Service Task Force. And you can see that most of the trials, the confidence interval crossed 1, even though overall we found that lifestyle modification favors the control. And lifestyle modification, even though very attractive from being natural point of view, in most of the trials, one, not all people were able to lose weight, and those who lost weight, most of them regained in long term. So what lifestyle modification or medication to treat with diabetes, which is better? So matter of perspective, when a patient comes to your clinic and you're talking to the patient, definitely the absolute weight impact, like somebody coming to you and you making him or her lose weight in certain period of time, medicines were supposed to be better because you're talking about a patient. But when it's public health impact, it is yet to understand, we are yet to understand whether medicines will be acceptable as a public health impact. Then it becomes a very complicated issue. Obesity in itself is a very complicated disease to understand and treat. We heard in IDEC also to Dr. Arya Sharma about what are the multifactorial etiologies of obesity: socio-cultural, environmental, epigenetic, genetic, physiological, behavioral. And that is why obesity is not as simple as that energy in and energy out. So the energy in is diet, exercise, we stop it. Energy in is diet and we reduce the calories, and energy out is exercise, we increase the exercise. And it's not as simple as that, because there are multiple other homeostatic pathways which play a role in not letting one lose weight, because the homeostasis is trying to prevent everything not to lose a person weight. And I think that is why lifestyle modifications, specifically in people who have been obese for a long period of time, they've developed a threshold of a particular weight, making them lose weight by lifestyle modification is not an easy task. We know from direct trial that almost 46% people regained weight. Those who went into remission with lifestyle modification regained weight, as well as the remission went away. At 1 year, almost only 20 to 25% people were in remission at the end of 3 years, and only 13% people were in remission at the end of 5 years of the follow-up. So for those 13% people who are getting managed very well with a lifestyle must be the choice of therapy. But we can see that 87% of people will require something more than lifestyle modification, and that was the case that was put up by a person who was talking in favor of diabetes prevention programs. And while when the lifestyle interventions do not work, what do we do with the 87% of people who are not responding to lifestyle therapy, was something that was debated by the other speaker. Especially when now that we have medications who can cause a significant weight loss. So with that, what we do in diabetes prevention program and look ahead study was that around 10,000 people together, if we consider a very strong lifestyle intervention, 16 individual, so if we talk about diabetes prevention program, there were 16 individual in-person counseling sessions in first 6 months. So you can see the intensity of lifestyle intervention that is required, with at least one other month session through month 12. And the mean average loss of weight that happened was 7 kgs at the end of 6 months, which was roughly around 5% of the initial weight. And the intensity is very high of the lifestyle intervention required, and people lose 5% of the weight at the end of 12 months. And again, when we look at it further, when the intensity of lifestyle modification sessions is reduced, the lost weight is regained. Similarly, in look ahead study, we had around 5,000 patients, and in 1 year, again 2 to 3 weekly group treatment sessions per month, and at the end of 12 months, participants lost a mean of 8.6% of the initial weight loss, while 68% only lost around more than 5% of the initial weight. But again, when the intensity of lifestyle modification goes down, the lost weight is regained. That's why the case was that lifestyle intervention is intensive. The requirement of lifestyle intervention, which can cause a significant weight loss, at least 5% of the basic weight loss, is very intense, very difficult to manage, both for patients as well as the caregivers, especially when we're talking about an epidemic of obesity and diabetes. We're not talking about one patient in a clinic or two patients in a clinic. We're talking about a huge number of patients, and providing an intensive lifestyle modification to these patients is not as easy as it seems. Secondly, when the intensity of lifestyle modification goes down, the lost weight is regained, because it's not only diet and exercise that is at the base of the obesity. When the lifestyle interventions like diet and exercise are intervened, there are other homeostatic mechanisms that stop the weight loss or make the person regain the weight by counter regulatory mechanisms. And I think that is what the second speaker spoke about. Regulating obesity by lifestyle does work. In some people it will work, and for them that should be the first line therapy. But for many people it will not work, and that is why drugs can come in. Now, there was no talk about which drug and what drug, but what was discussed was that the main pipeline of the therapy is coming from the incretin pathway. More GLP, as we have heard, GLP receptor agonists. We have semaglutide in India, not for obesity management, but for weight management in people with diabetes. But I guess in coming future, we would have this drug approved for obesity management. In US now, another drug which is US FDA approved is tirzepatide, which has seen to cause 15 to 20% of basic weight loss. So that is almost as good as a bariatric surgery, and they are also talking about these drugs making bariatric surgery less required or less attractive, because if a drug can make you lose weight 15 to 20% of your basal body weight, then why would one go for surgery is the case. So these GLP-1 receptor agonists, dual receptor agonists, triple receptor agonists. So in all, there was a talk that around 100 plus molecules acting through different pathways of homeostasis, tackling against obesity are in pipeline. So in next couple of years, I think there are going to be a lot of molecules coming in for management of obesity. Whether that will replace lifestyle modification or it will complement lifestyle modification, what are going to be the long-term effects of these drugs, what comes along with it, what are the unfavorable effects of the drug, will they cause may people lose more weight than what we intend? These are the questions that we'll have to look ahead for, and only time will tell us what to do. Cost challenge, of course, any medications which come in the market in the beginning will be costly. But if their need is so high, and once the biosimilars or generics come, of course, we know that the initial cost that comes very high goes down. So what we have learned is that managing diabetes and obesity with lifestyle modification is very attractive, would be our first choice, but it's not enough to deal with the epidemic of these disorders that we are seeing, because lifestyle intervention is not easy. It may not be as easy to sustain as it seems. Relapse is a rule. Very few people maintain. Many of them will regain the weight. And now we have a lot of anti-obesity medications coming in, which might help us to deal with the epidemic of the obesity and diabetes that we are dealing with. So I think that was a very strong debate.
Thank you, Dr. Anjali. I think the perspective was the presence of so many of anti-obesity in the pipeline, drugs in the pipeline. Probably in a couple or in the next 5 years, we might have a full bouquet of anti-obesity drugs to manage obesity over and above the lifestyle, as we talked about. And definitely we'll go into the discussion, but I think we hand it over to Uma for another commercial break.
Thank you. Thank you, sir. And ma'am, you really owned the slides. Nobody could have said that you are standing in for somebody else. So great job there.
Thank you. Thank you so much.
So this is a video play. Thank you by our sponsors, Sinocare. The tech team, I request you to please play that.
iCan, your new continuous glucose monitoring system for all people with diabetes. Easy to apply and comfortable to wear. Real-time glucose monitoring, continuous 3-minute connectivity. Every time iCan. Forget about the unawareness of hypo and hyperglycemia and pain of finger pricks. Forget about interference from vitamin C. Forget about worries about water when you're bathing or even surfing. iCan is water resistant to 8 feet for 2 hours. iCan has a 15-day wear life. With iCan CGM app, you can check your blood glucose anytime and anywhere. With iCan Reach app, you can share your data with loved ones. iCan makes managing diabetes easier so that you can enjoy activities of daily living effortlessly. Set your own alerts for low and high glucose levels. No worries, even at bedtime. iCan provides real-life accuracy. iCan empowers you with self-management. Your choice, iCan. SanoCare, caring for love.
Thank you.
Thank you. Dr. Anjali, I think you really spoke well on almost, both the sessions which you took. And the ADA learnings are important tools basically for all those who have not attended them, or even for those who have attended but have missed out on certain aspects or certain part of the ADA. And definitely, the ADA conference in Orlando offered numerous insights and key takeaways. And let's go to the first topic of yours, the primary care, which you talked about. We obviously in India and US, the primary care is very different. But
Yes.
definitely, one thing which is emphasized is you have to have enhanced screening and diagnosis so that this earlier screening recommendation which was given in ADA is common to both. I mean, that has to be implemented, whether it's US or India. And then the risk assessment tools, which actually they focused on that we need to identify those high risk groups so that we can do the screening at the earliest and at least be very intensive in the initial aspect of management. So that was another thing. And obviously, as you talked about the various technology which need to be used at the primary care.
Absolutely.
Yeah, so that was
Because
CGM which you
nowadays
talked about.
at primary care, we are only talking about glucose. Most of the times, what happens at primary care is the patient is asked to do fasting PPH, HbA1c and come back. And that's getting repeated. And only when some complications happen, then we do all the investigations and then send to the specialist for further referral. And I think that should stop. At primary level, we need to think as the patients with diabetes in a holistic manner, that we need to do glucose, we need to look at the lipids, we need to look at their livers, because we don't need to do fibroscan, we don't need to do ultrasound. We can do a simple FIB4 score.
Absolutely.
Somebody who is getting hyper, continuous glucose monitoring can be easily done. We need to make sure that we're not at least increasing the obesity issues by using drugs that can increase the weight. So I think if we do these things, there is a lot that can be done at non-specialist levels.
As you said, yes, emphasizing a holistic approach. And I think the most important aspect of a holistic approach would be the psychological support which we give to the patient.
Absolutely.
So that can easily be done at the primary care levels, because behavioral health modification or integration of that into the management will definitely work. And it can always be under primary care. The tools which you talked about, identifying the microvascular and the macrovascular complications the earliest. And you don't need too many gadgets for that. As simple gadgets, as you said, monofilament can do the work for the neurological assessment. A simple AI-enabled retinoscopy can do the work for the identifying the retinal changes at the earliest. And similarly, a simple what we always do. So we need to remember is that we need to incorporate that in daily practice. So it can be done at the primary care level. I totally agree with you. And this is what the ADA learning was all about. So thank you. I think very well dealt as far as a lot of emphasis was there on the primary care, I think, so in ADA. And as you suggested, as you said, that there are different tools which were talked about and at different times of ADA meeting. So that's very well taken, I think. So do we have any question on it, Uma?
We don't have questions, but we do have comments thanking Anjali ma'am for very good presentations.
Thank
and not
you.
only thanking, she has to be thanked twice, actually. Basically, she took the topic of Dr. Neeta so easily and put her inputs so very well. Thank you, Dr. Anjali, for that as well.
Thank you. Thank you,
I
everyone.
think, nothing much to add as far as the primary care is concerned, but we can always discuss upon this particular debate which you're talking about, the diabetes prevention program and the use of medication, as you said. Only 13% may be the one who can really have some improvement with the diabetes prevention program, because not only it is time consuming, you have to sit with the patient. Patient need to be given adequate counseling sessions, and there can be variable outcome as well. I mean, it cannot be uniform outcomes for all. So these two are the major challenges as far as the prevention program is concerned. And along with that, obviously, you need a lot of resources. See, it's not an easy job. Just a physician sitting, it won't be very easy for that. Almost we need a good support staff there. So medication will come in as and when the DPP program fails. So, and that is what the major impact of the whole ADA was. I think last three ADAs, if you have visited, the anti-obesity has probably taken over in most of the year. So the anti-obesity was discussed at length. Drugs were discussed at length, and lots of trials were discussed. I think the SELECT trial, which was spoken about, the SCALE trial, and all other trials which were spoken about, STEP trial, all has given kind of a indication that these are the molecule for near future, and they may have to be incorporated in managing obesity, because obesity happens to be the pathophysiological base of all metabolic ailment. So I think DPP4, I mean the diabetes prevention program should always be there, and to complement that, probably the anti-obesity drugs need to be initiated. So any comment and any questions on that, Uma? If we have any comments or any questions?
No, sir.
All right. So basically, she has wrapped it up very well. I think so, and there's not much of a question there, and very clearly shown in the direct trial, the sustainability of the is a big issue. Even at the end of first year, the percentage decreases. Those who can maintain even 5% of the body weight. So basically, the newer molecules, whether it's a simple GLP-1 or GLP plus GIP, or with the glucagon or the triple therapy, as we did right, is the one which is probably in the pipeline to be very soon there, and tirzepatide is probably already there. So these are the drugs. Almost what I know, the triple drug has probably shown a weight loss of about 24%. So that's much better than the bariatric surgery as well.
Absolutely. So, absolutely.
Yeah. So anti-obesity, as you said, first and for identifying these muscle patients is extremely important, even to the primary care or later, and then incorporating the necessary management tool would be good, right? So, I think we have really spoken about most of the stuff. Only concern probably with these molecules will be there is the availability, accessibility, and adaptability.
Affordability.
So, affordability. So that will always be a concern. And it does take time for the generics to come in.
Absolutely.
But generics cannot be innovators, right?
Absolutely.
So, yeah.
So we'll have to wait and watch, even though we now think it seems to be a very attractive therapy. But as the time goes, we'll know. Everything will have its pros and cons.
Yeah, absolutely. We don't have the long-term kind of effects.
Absolutely.
So we have the short-term benefits. Yeah. So we have to be a little bit cautious there and need to identify the patients in a proper way, and then incorporate these tools in the management.
Also have to see, we'll have Western data now. We'll have to see how those things act when we use them in the clinical setting of India.
So we have enough experience, I think, with the liraglutide. We have reasonable weight loss, but even with oral sema, I think 2022, it was January 17th when it was launched. And since then we have been using it, and it is definitely a standout molecule, I would say.
Right.
Only problem probably is the cost.
Right. And so we are using these drugs for weight management in patients with diabetes. Even though I'm aware that there is a lot of off-label use of semaglutide in non-diabetic obesity, but we are yet to understand how our people will react to an anti-obesity medication. Now, because we're talking about a disease which is a complication of diabetes, and we're treating that disease, we're not yet treating obesity as such as a disease with a medication. So I think there is a slight change. I'm sure at clinical level, at many places, these drugs are actually patients are coming up with asking these drugs for weight management.
Yeah.
But we still do not have the DCGI approval for using this drug in non-diabetic obesity. So I think our
Right.
regulatory authorities, our people, our prescribers will have to see how they react to an anti-obesity drug without any other comorbidity, like without diabetes, without hypertension, just to make them lose weight. Because there are a lot of other
Agreed.
aspects, cosmetic, aesthetic, some off-label use of these drugs, people using the drugs without recommendation. A lot of things will come up if we are talking about these drugs as anti-obesity management without any diabetes, hypertension. I think we'll
Yeah.
have to wait and
We
see how
need to wait.
we
We need
react.
to wait.
Yes,
Yeah, we need to wait. We have to get the proper ethical clearance. Otherwise,
correct,
it's very difficult to even use off-label. Off-label
correct,
means we have to take a consent from the patient in
correct.
documentation. So that's
Absolutely. So we
important.
can't get the
But
data. We don't know what happens with that.
but then it is being misused as well. I can give you one example. A doctor of Singapore has prescribed this patient who had diabetes post-pancreatitis, and then just for the sake of obesity management, because he was obese, this drug was incorporated and was not even briefed about how the molecule need to be taken. So this do happen when we try to rush into
Yes,
anything. Probably
yes,
will end up with these few, and we might have a rather it will miss service or disservice to the molecule as well. So
absolutely.
I think, yeah, I
In
think with
US
a great
also, these
discussion
are
today.
drugs. These drugs are used by non-medicos over the counter. I don't know. I mean, somehow there is a very good chance that such molecules can get misused. But we'll have to keep our fingers crossed as to how we use them.
Yeah, even the Middle East is taking all the molecules from India because it's not available still in the Middle East, and we are not
Absolutely.
sure how they are being used. And but somehow, as because they do show some weight reduction, and we
Yes,
don't have a long-term data after that, so
absolutely.
we'll still
So we
in the
have a
initial
nuclear power.
stage.
Let's use it judiciously.
Right, right. Yeah, absolutely. I agree with you. And I think today's discussion was apt, and probably we have tried to cover maximally. And I thank you again for
Thank you,
actually
sir.
taking both the topics together. And if more permits, I think if no questions are there, has Dr. Amit joined? Not he
No,
messaged
sir.
me that he is there. Okay, fine.
He did join
So
right at the beginning.
yeah, now he is in a social networking events. Anyway, not at all an issue. I think we covered Uma. I think so. Dr. Anjali has spoken very well on both the topics. So, do we really need to discuss anything further? And no questions are there.
There are no questions on the platform. No more.
We can wind up then.
Yeah.
Thank you both for your valuable time today. I think you've really, both of you have outdone yourselves in that sense that you've carried this entire session on your shoulders. So thank you so much for that. And as far as learnings from ADA goes, tomorrow is our last session. So it was a 10-day program that has been very well received. So this is already a hit, which is a very good thing. And I think bringing back learnings from any session that others might not have privy to is a great way of returning back to the community in that sense. So I think this is a great deal that's happening. And again, thanking our sponsors for the day. Thank you all.
Sure. Thank you. Good night.
Thank you. Good night. Thank you.